Well, good afternoon. Thanks for having me. I bring you greetings from the great state of Ohio. Go Bucks. All right, all right. It started out pretty well there. I was going to say that line actually goes over a lot better in Pennsylvania than Michigan, but maybe not. Maybe not. I'm here obviously to speak to you about opioid abuse and addiction in the state of Ohio and what our state's prescription drug monitoring program was established to try to do about it. And I can tell you it's been an evolving process. I understand that you all are getting started now. Our program started in 2006, and it's probably not until now, maybe a decade later, that Ohio is really beginning to feel that the program itself the system, I should say, is beginning to have the desired impact that of saving lives, of getting people to identify people who are maybe drug seekers and unintentionally so, and physicians who maybe need to have some additional training to address these sort of topics of overprescribing in many cases. Let me start by telling you a little story about one of our members, as a matter of fact. Dr. Turner is an orthopedic surgeon. He has been since 1978. And he spent nearly 4 decades building up his practice as an orthopedic surgeon, um, a stellar reputation in the central Ohio community in the area. Served on several volunteer roles within our community and so forth. And in 2013, as he marked his 35th year as a physician, he began to think towards retirement. And it was about that time that he received a letter from the State Medical Board of Ohio. Didn't really think much about it, although his mind did, as he tells me, did kind of shift to many of those emails that he automatically deleted. Many of those emails that contained the subject line that was pertaining to the prescription drug monitoring program in Ohio. Dr. Turner did not feel that he was someone who, he's not a pain expert. He didn't feel he was overprescribing, and so he ignored many of those emails. It was certainly unusual for him to receive a letter from the State Medical Board of Ohio. They typically would shoot out emails, not so much a letter. Still, was not necessarily alarmed, but he did go ahead. He opened it up and he read it. And in part, it read, Dr. Turner, we have investigated your opioid prescribing habits and have found that you are routinely exercising judgment that is well beneath the minimum standard of care. Your medical license is suspended for a period of 6 months, effective immediately. Dr. Turner tells me that his mind quickly ran through all of the stages of grief. First was denial. Surely this has to be a mistake. You know, I've done the same thing for over 3 decades. This has to be a mistake. Anger. How dare the board target me in this way, embarrass me? I have a stellar reputation in this community. Then he went on to bargaining. So he says, okay, all right, maybe I missed something here. Honest mistake. All right? Doesn't work in Ohio, unfortunately. Depression. Okay, I'm going to lose my practice now. I'm so close to retirement. I'm going to lose my patients. Been working for this for over 3 decades. I'm approaching the near end of my career, and now I have to deal with this. And then finally, acceptance. He finally realized that some of his prescribing habits indeed were incorrect. And the reason is because as changes were taking place with Ohio's prescription drug monitoring program, he was not keeping up with many of the changes that were taking place. In Ohio, our program is called OARS. It's short. It's Ohio Automated RX Reporting System, but everyone calls it OARS, OARRS. And in Ohio, as the rules and everything else change, and it has evolved, as I mentioned earlier, as an evolving process, it is up to the physicians and the prescribers in Ohio to educate themselves, to keep up to date on what's taking place. And I can tell you that over the last few years, as Ohio has sought to try to address this issue of opioid abuse and addiction and people dying, more and more legislative action was taking place that was related to our prescription drug monitoring program. It's a lot for a physician to keep up with. We, of course, have done our part at the OSMA and trying to keep up and make sure that everyone is aware of what's going on. But some folks fall behind, and some people aren't aware, or maybe they're just honest mistake from Dr. Turner. They're not paying close enough attention, and they suffer a loss of their license for some period of time. I'll give you an example. In 2014, 1 out of every 4 inquiries from the state medical board was related to prescribing, meaning someone had called the state medical board. This is how it's initiated in Ohio. Someone calls the state medical board and says, I believe Dr. Turner is not prescribing properly. He just gave someone 30 oxycodones. That initiates an investigation. 1 out of every 4 in that year. It was a significant jump from just several years earlier when this was sort of an unheard of topic, not topic necessarily, but at least they certainly weren't delving into this many investigations or looking into this type of prescribing problem in the state of Ohio. So ORS was established in 2006 as this online web-based clinical tool for the prescribers to be able to look up the prescriptive history of an individual patient. And it was also information there that allows the state to keep tabs on physicians who are prescribing to see what your habits are and how much are you prescribing and whether or not you have the patient base that mandates that you were prescribing as many opioids as maybe you are. So it's sort of a twofold system. Yes, it's to protect the patient, but it's also to kind of identify and help train physicians. Doctors, pharmacists, licensing boards, and law enforcement agencies, they all have opportunities to access records through ORS in varying degrees. For example, law enforcement, they will only be able to access it if it's part of an investigation that is a drug-related investigation. Obviously, pharmacists and physicians have much greater access to the system itself. The system is operated in Ohio through our state board of pharmacy, but it's our medical board that has the investigative authority over the program itself. But while ORS had been in place since 2006, as I mentioned earlier, it's been a slowly evolving system whose incremental changes are typically brought on by complaints from the prescriber community because of many of the challenges that we have faced through the years in trying to get the system in where it most needed to be. It got to a point where it was so cumbersome that no one was using it. So if no one's really using the system, then what good is the system? Yet at the same point, many physicians were still being held to a standard of making sure that they at least made reference to it and checked it. It's kind of how Dr. Turner fell into the problems that he had. To address those challenges, let me give you another quick story. In 2010, in rural Portsmouth, Ohio, it's a small city, it's about 11 square miles in southern Ohio, right on the Scioto and Ohio River, just across West Virginia on one side, Kentucky on the other side. 3 states kind of meet right there. This small area had become known as the pill mill capital of the United States. Maybe you heard about it. The New York Times wrote about it. 60 Minutes did stories on it. USA Today came in town. This one small area there in Ohio had become known as the pill mill capital of the United States. It was it is the seat of Scioto County there, which has the highest rate of prescription drug overdoses in our state. 1 in 10 babies born in the county were addicted to drugs. The number of pills prescribed in this county was the highest per capita in the country, which is how it earned the title as the pill mill capital of the United States. Oh, and most of the users were young adults and teenagers, some as young as middle school kids who were using these products. It's because of Portsmouth that Ohio's prescription drug monitoring program finally became meaningful, if you will, and a significant program. Why? How? It's because it was around that time that we had just elected a new governor, and our governor our current governor, John Kasich, took office in January of 2011 on the heels of all the Portsmouth stories that were coming about, and he immediately made prescription drug abuse and addiction, opioids, his number one priority to address. And he did it in such a way that he decided that physicians were going to be his target initially early on in trying to address the pill mills and to address this problem. 4 months after he took office, he signed a bill known in Ohio, everyone still refers to it as House Bill 93. House Bill 93 was the pill mill bill. This was the bill that had all the provisions that shut down the pill mills in the state of Ohio, but it also gave all of the licensing agencies in the state of Ohio the authority to use administrative rules to help bolster and implement, give more teeth, if you will, to our ORS program. And so our state medical board did exactly that. I remember when he signed the bill, and one of the lines that he said, targeting physicians, if you overprescribe, we're coming after you. That was the message from our governor that day. House Bill 93 not only put the clamps on the pill mills, but again, it gave new life to ORS, because many of those challenges that the system had in place were suddenly going to be addressed. Challenges such as the infrastructure, the IT infrastructure, the web-based portal that was used was ineffective. It was not very intuitive. Once you were able to log on, it may take you 5, 10, 15 minutes just to look up one report on a patient. Who has time to wait for that when you have a waiting room filled with patients who are waiting to see you, who you are waiting to see? So it was not a very effective system. This was about the time when the Portsmouth was a trouble as it was, and at that point, while ORS had been in place for 4 or 5 maybe years at that point, still only 1 out of every 5 physicians in the state of Ohio were registered to use the system. And of that one out of those every 5, many of them were not using the system itself, because you had to register to use it. So yes, they were registered, but they weren't actually using the program because they felt it was too slow, it was ineffective, and it wasn't helping them be able to continue to see their patients and not adding to their level of treatment of care for them. Another challenge was because of the privacy concerns in the state of Ohio, the state would not allow anyone other than the attending physician to access the system to look up a report on a patient. So not only is the system very slow, but you're not able to appoint someone maybe within your office, an office assistant, maybe a nurse or someone else. Can you look up this report on this patient while I go and talk to her? You could not do that. So another reason why many physicians, and again, it's not a mandatory system at this point, it's another reason why physicians chose largely to sort of ignore the system that had been in place for several years. And then another was that, so if you have a system that's too slow, it's not moving very well, you don't have doctors who are using it, then the biggest problem with it was the fact that it was void of data. There wasn't much there. It was designed for you to be able, if you had a concern about a patient, you know this patient is showing some drug-seeking behaviors, perhaps. You have a concern. In theory, you can look up their record and you can find, oh, it's because they've had this many prescriptions of opioids, maybe within a very small period of time. But if physicians weren't using the program, then the data wasn't there. So now you have yet another huge challenge to the program. This was about the time when Portsmouth emerged. And when Portsmouth emerged, essentially gave Ohio a huge black eye as we became the pill mill capital of the United States on this issue. And people wondered, how could that happen? Why aren't you all doing more about this? You have a prescription drug monitoring program, but do you really? If no one's using it, if it's ineffective? And so that's where, when that happened with House Bill 93, that came into place and some of the rules and different things that were taking place there. Over the last 5 years, we have seen a number of changes that has kind of brought us to where we are today. I'll give you five things that have occurred or in a process of occurring that has actually made the system that was once rendered very ineffective is now a very effective program. One, the state decided to spend a little bit more money on the infrastructure. Maybe a little better portal, something is better there so that when you want to log in, you don't have a problem logging in. If you lose your password, you can actually get your password recovered within maybe a few minutes instead of having to wait several hours. So they put some money into that, and that helped speed up a system that previously may take 10 to 15 minutes to pull up a report. Today, you can usually get a report in about 60 seconds. So it's a significant change in that regard. House Bill 93 also required prescribers who furnish controlled substances from their office to report their information to ORS. So this was sort of the first step towards some sort of mandate, making some aspect of the system mandatory. Now, it's only for those who are furnishing, meaning this is coming directly from their office, not being dispensed as a prescription, if you will. The third thing that happened was that now a physician, remember before you had to look up the reports yourself. Well, now in Ohio, you can have as many people as you want who are working within your office act as what they're called delegates to do to do a search, a report, a search on a patient for you. So now you don't have to leave the room with your patient to get that report, to get that information. Now, comes with a caveat, because of all the privacy concerns and everything else that are related to this, these reports can only be viewed by the physician and the patient. It's not to be used in any other way. There are some criminal charges that can be attached to misusing or violating this sort of information. This is why initially delegates weren't allowed to use the product, but now they are. And so with that, the individual person is responsible, but they work under the guise, under the direction of the physician. So if that person gets in trouble, then the physician gets in trouble as well. So you need to make sure that you can have them working for you, looking up this information, make sure that it's someone who you can trust in that regard. The fourth thing, and this was a very significant one, was in just a year ago, in April of 2015, a new law took effect in Ohio, which made it mandatory for anyone who prescribes opioid analgesics and benzos to register with ORS. This was a significant move as well for the state of Ohio. That same law also requires physicians to make periodic ORS requests at least every 90 days after the initial ORS report on a patient, if requested. And then the last thing that has not yet taken place yet, but has been announced, was last October, the state of Ohio announced that it was making a $1.5 million investment to integrate our ORS system with electronic health records and a pharmacy dispensing systems across the state. So the idea there is just to eventually we'll get to one click, and you'll get more of the records, more of that information right there in your hand. With these changes, a system that just 5 years ago only had about 5,000 registered users, last year had over 36,000. So it's having an impact. The changes, we had to learn from many of the mistakes that we had made along the way. Now, I will tell you that at every step, the Ohio State Medical Association has sought to play a prominent role in addressing, ORS and the issue of opioid misuse, and abuse, and addiction. Obviously, as advocates and champions of Ohio physicians, we wanted to make sure that these rules and regulations that were going to be imposed were going to be reasonable for physicians in the state. But I'll tell you that there is another reason why we also felt, we've always felt, very close to this topic. Prior to when I started there, my CEO, Brent Mulgrew, maybe some of you in the room know Brent. Brent was there. Brent was the CEO. He became CEO back in the 90s. And one of the things that he remembers as he became the CEO was that Ohio, it was just at a time in the 90s when the federal government was pushing pain as a fifth vital sign. Several states passed legislation related to that, including Ohio, and the OSMA was very aggressive in trying to help push that, to support that, with programs and different things like that we were sending out to physicians to tell them that it's okay for you to do this. It's okay for you to treat pain. It's okay for you to treat pain with these painkillers. At the same time, there was a lot of direct-to-consumer marketing from companies about these drugs, often saying that maybe they did not have the addictive nature that we later learned they absolutely have. So as an organization, we've always felt that we were responsible in some part, maybe helping to train a generation of physicians to use painkillers, drugs, to treat pain. We're now trying to reverse that with support of programs such as OARS. We also established a program just a year ago, a physician education training program called SmartRx. That's an online training tool which features 4 different videos, and it covers topics such as OARS. What are the rules and regulations related to OARS that you absolutely need to know? And we keep it updated, because if something happens in the legislature tomorrow, we need to make sure we're going to update that so that you are up to speed on that. What are some of the best practices for treating patients with pain? It's another video. Another relates to what are some non-pharmacological ways to treat pain, some alternatives to prescribing a pill. And then fourth, how do you talk to patients about this? What do you say to patients who are demanding that they need more and more of this? A patient education sort of component. So with SmartRx and our efforts working with the governor's office on some various pain-related treatment guidelines, we're beginning to see some changes in Ohio. In Ohio, there were 40 million fewer doses of opioids prescribed in 2014 compared to a year earlier. I don't have the 2015 figures yet, but we think that it was continue to trend in that direction. Doctor shopping dropped by more than 65% from 2009 to 2014. The number of patients with an MED of greater than 80 dropped by 22% from 2010 to 2015. And the number of prescribers, as I mentioned earlier, who are now using OARS has jumped from 5,000 to more than 36,000. So sure, there's plenty of work that still needs to be done, obviously. For example, while we had the drop in fewer doses, 40 million fewer doses, we still had, check my figure here, 750 million doses that were prescribed. Still quite a bit. It's enough to provide 65 pills for every man, woman, and child in the state of Ohio. So there's still quite a bit of work to be done. But with the changes that we have seen over the last few years, there is a sense in Ohio, even among many of the physicians, and I will tell you now, I'm not here to tell you that it's a perfect system. I'm not here to tell you that physicians love it. But there is now a sense that it is an effective tool. It's a tool that can be very helpful.